webinar available on the website. Due to large number of attendees, we will keep all participant lines in listen mode. You may ask questions at any time during the presentation using the Q&A feature that appears in the Zoom window, and we'll be answering those questions during the Q&A portion at the end. We'll also be conducting a few short polls throughout the presentation, and we encourage you to participate. Finally, if you have any technical difficulties, please contact Uloma Jacob at the email address listed here. Next slide. Here are today's speakers. I'm Kendall Hall, and I'll be moderating this session. Joining me, we have Judy George from the Center for Quality Improvement and Patient Safety at AHRQ. Judy is the program lead for the Quality Indicator Program. We have Carrie Calkins and Sheng Wong joining us from the Quality Indicators Analysis and Support Team at Mathematica. And from the Software Maintenance and Dissemination Team from Pantheon, we have Veronica Hernandez and Vivek Kumar. Next slide. Here's our agenda. So we're going to start with a brief overview of the Quality Indicator Program, and that will be conducted by Judy. Next, we'll provide an overview of the version 2025 software and updates, including key logic changes and some key refinements. We'll also cover the maternal health indicators beta software. We will also present some software updates and usability improvements and look at version 2025 resources. Lastly, we'll conclude with the Q&A session. So we're going to go ahead and pull up our first poll question, and please respond to the following. Is this your first time joining a webinar on the AHRQ Quality Indicators software release? All right, it looks like a majority of our folks is the first time on this webinar, so thank you for responding. A few of you have joined in the past, and a couple have joined every year, so welcome. Now I'm going to turn over the call to Judy George to provide a brief overview of the AHRQ Quality Indicator Program. Judy?
Thank you, Kendall. Hello, everyone. My name is Judy George. I oversee the Quality Indicators Program at the Agency for Healthcare Research and Quality. And on behalf of our agency, AHRQ, or AHRQ, I am delighted about the promising enhancements to the quality indicators this year, and welcome especially to all of you who are new members of this webinar. I'm going to breeze through highlights of our overall program, but I commend you to go to our website for more comprehensive information about our program as well. So next slide, please. Thank you. The quality indicators were originally developed at the request of state organizations and hospital associations as a quality improvement tool within AHRQ's Healthcare Cost and Utilization Project, or HCUP. A major strength of the quality indicators are that they are developed and tested using HCUP all-payer data, which represents over 90% of hospital discharges in the US. Next slide, please. With over 60 measures covering a broad range of conditions, procedures, and populations, the quality indicators have broad applicability and can be used with readily available administrative data. Next slide, please. So, in fact, that broad applicability is reflected in the type of users of the quality indicator. So let's bring up the next poll question, Jayashri. Thank you. So all of you on the call, can you please answer the question here? Which of the following best describes your organization? We'll give folks a few seconds here. All right, let's see those results, Jayashri. Okay, so a majority, the wide majority here is hospital health system. We have followed by third-party vendors, and then hospital health systems, health plans, and then our colleagues in federal agencies or federal health systems. Great, thank you so much. Let's go to the next slide, please. Recognizing the broad range of users and use cases, AHRQ is strongly committed to the rigorous scientific approach to developing, maintaining, and retiring quality indicators. Our measure development team annually evaluates the scientific acceptability of the AHRQ quality indicators. So I commend all of you who are new to our program in this webinar to take a look at our website, which includes empirical methods and scientific rationale documentation about each of our measures. Next slide, please. So when we talk about the quality indicators, we're referring to 6 sets of measures that are part of them. Those cover inpatient care, patient safety, prevention, pediatric, and as of 2024, maternal health. Next slide, please. And in fact, I'm very pleased to share the newly released additions to the maternal health beta module. Over the last few years, AHRQ has been focused on identifying measurement gaps related to population-level outcomes improvement. And through public input that AHRQ has received, we've learned that there is a need from the field for useful measures around maternal health and MR delay diagnoses. AHRQ convened expert work groups to identify important, useful, and valid potential measures. We conducted measure testing, and while coordinating these efforts across federal and national efforts. And so we are releasing beta measures and exploratory research tools for maternal health and diagnostic excellence. So for all of you on the call, these are intended for you, our field of quality indicator users, to confirm their usefulness in your environment, and AHRQ relies on your input for these tools. So next slide, please. To make existing quality indicators and these new measurement tools as accessible as possible, we make available free software, which allows you to compute observed and risk adjustment measure rates from your own data. Next slide, please. And again, to make the software as accessible as possible, there are options regarding those free software. For those who are not programmers and want an option that is point and click, there's Cloud QI. And for those who wish to code and prefer SAS, there's SAS QI. Let's bring up our next poll question, Jayshree. Great. Okay, so all of you attendees, are you interested in using programming languages other than SAS for the AHRQ quality indicators? Please take a second to respond to the poll question. So over the years, we know that there are those who prefer SAS, of those who are coding and using the code, and then there are those who are more interested in using other newer languages. And your responses will help inform our plans. All right, let's see those results, Jayshree. Okay. So most of you who have joined the call do not program, and there seems to be an even preference here. So no on the more, on the coding side, and then followed by Python, and then other or R. So when we get to the Q&A, love to hear more about the other that you're thinking about. We'll take these into consideration. Please reach out through our TA support email for any other comments. That wraps up our program overview, and I'm going to ask you to take a look at our website, previous webinars that includes more comprehensive details of our program and any of the content that I have presented. So with that, I will turn it over to our measure development team. Shane, you can take it to the next slide.
Thanks, Judy. I'm Sheng Wan, a principal data scientist at Mathematica. Our team supports AHRQ with research software refinement and development, and I will be walking you through the main software updates in the next few slides. Next slide, please. This year, we've updated the version 2025 software using the most current HCUP tools to ensure it reflects the latest coding standards. The updates include the fiscal year 2025 ICD-10 code updates, the POA exempt list, the CCSR and the PCrossR tools as highlighted on the slide with their corresponding versions. We also used the updated Alec Hauser comorbidity software to create risk factors for risk adjustment models. Next slide. By applying the updated tools and codes, we refined the quality indicators to ensure they remain aligned with the current coding standards. Most of the v2025 refinements were driven by user inquiries and internal clinical reviews. Our team thoroughly tested these refinements to assess their impact before implementing them in the version 2025. We updated the reference population rates, signal variance, and parameter estimates for the risk adjustment models. And we also removed PSI2 from the software. Next slide, please. For the v2025 release, most modules had no major logic changes, but a few important refinements were made. The PQI and IQI modules remain unchanged. For PQE, we expanded coverage by adding new codes for tooth disorders and impacted teeth. In the PDI module, we updated the denominator exclusion criteria to account for advanced heart failure and left ventricular assist device insertion. Similarly, in the PSI module, we added those same exclusions and removed some fracture codes for PSI 8 in the denominator exclusion. For the MHM module, we added an exclusion for patients who were transferred to another short-term hospital. Next slide. For v2025, we also updated the reference population using the most up-to-date HCAP data. For hospital-level indicators, we incorporated 3 full years of SID data from 2020 through 2022. For area indicators, we used the 2022 data from both SID and SAD. The version 2025 software also now includes planning region information from Connecticut State, which was applied in the risk adjustment models for the area-level indicators. In addition, we updated the county-level population counts using the most recent census data. Next slide. For v2025, we made some refinements to the risk adjustment process. First, we introduced new candidate risk factors for specific quality indicators and provided the clinical rationales in the empirical methods document. Second, we updated the feature selection strategy for the COVID-19 quarterly adjustment. In the previous version, v2024, COVID-19 or quarter was always added back into the model if it was dropped during the feature selection process. With 2025, COVID-19 and quarters are now treated like most other risk factors and subject to feature selection process. This change creates a more consistent and data-driven approach to the risk adjustment workflow, and you can find more details in the empirical methods document. Next slide. This table highlights the relative changes in observed rates when applying v2024 and the v2025 software to the same reference population used for v2025. Overall, most changes are modest, generally within a few percentage points. We've listed the indicators where changes exceeded 1% or where important refinements were implemented as described in the previous slides. The last 2 columns show the number of key set name or logic updates affecting the numerator or denominator counts, which help explain the observed changes from v2024 to v2025. The largest shifts were observed for PSI 8 and IQI 21, 22, and 33. For all other indicators, the rate changes were minimum, staying within plus minus 1%. For more details, you can review the v2025 changelog. Next slide, please. This slide highlights the impact of the v2025 updates on PSI 90 composite weights. For this release, the hum weights remain unchanged, and the numerator weights were updated. We've listed PSIs with changes greater than 3%. As you can see in the table, PSI 9 and 11 both decreased by 70% and 10% respectively, while PSI 3 and 15 increased by 13 and 11%. It's important to note that although PSI 9 shows a 70% decrease, its overall influence on PSI 90 is limited, since its weight is only about 4%, and the same applies to PSI 15. For all other indicators in the composite, changes were minimum, within plus minus 3%. And these changes were driven primarily by shifts in the numerator counts from v2024 to v2025 for the individual PSIs. Now, I will hand this over to Carrie to talk about the key updates to the MHI and the diagnostic safety measures for the v2025 software.
Thanks, Sheng. I'm Carrie Calkins, and I'm the Deputy Project Director for the AHRQ Quality Indicators Project at Mathematica. For v2025, we released new MHI beta software that addresses maternal health during delivery and in the postpartum period. The measures cover topics related to severe maternal morbidity, maternal deaths, and behavioral health conditions. Next slide. In total, there are 11 maternal health measures included in v2025, again, covering SMM and hospital death, mental behavioral health, and these data also use both inpatient and emergency department data. The beta version is focused on population level analyses, surveillance, quality assurance, and research, and is not intended for accountability, and it's not risk adjusted for reporting. We invite you to provide feedback to the QI support email listed on this slide, and we have technical specifications and details available online. Next slide. I did want to also note that we are providing a research tool that includes 4 exploratory maternal health measures focused on behavioral health during the postpartum period using inpatient and emergency department data. These follow the same specifications as the postpartum mental health measures in the MHI beta module, but they expand the follow-up period from 42 days to 365 days. We provide technical specifications and a scientific rationale online, and these are targeted at users that are able to link patients within emergency department and inpatient data for a longer follow-up period. All right, now I believe we will see a poll question coming up. So this question is focused on what is your interest in using the new maternal health indicators and or the exploratory maternal health measures? Please select an answer. Give a little bit more time. Okay, I see the results are coming up. So about 2/3 of people are either actively using the measures or interested in learning more. Thank you for your response. Next slide. Moving on, we'll talk about the ongoing efforts related to diagnostic safety at AHRQ. The first one is a planned research tool focused on the symptom disease pair analysis of diagnostic error, or SPADE, research approach. This tool will be released this fall. It's a Python-based software that's meant to support diagnostic safety researchers and those focused on quality improvement. And it looks at a linkage between ED visits and follow-up admissions, where the ED visits have symptoms that are suggestive of a downstream disease process occurring, and allows users to track within their data the rates of ED visits closely followed by an admission for related disease. The software provides rates derived from linked SID and SED data across 15 states that have the capacity to link. We provide 2 symptom disease pairs within the tool that are based on prior literature and existing measures. One is benign dizziness and stroke, and the other one is chest pain, dyspnea, and tachypnea with AMI. We also allow users to specify their own symptoms and diseases for exploratory research. Next slide. We also wanted to alert you to the diagnostic excellence indicators that are coming soon. AHRQ is developing a new set of electronic health record-based measures that are focused on breast, colorectal, and lung cancer diagnostic excellence. Topics include timely follow-up after abnormal cancer screening, diagnosis at a late stage, and emergency presentation at diagnosis. We have been coordinating with other HHS agencies, including CMS, on these measures and will release detailed technical specifications this fall, followed by a full release of the beta module in fall 2026. Now I believe we'll have a poll question coming up. So this is a two-part poll question. First is, what is your interest in using AHRQ's diagnostic safety technical specifications and/or SPADE research tools? And then another question specifically related to your interest in electronic health record-based measures from the AHRQ program. And we'll wait just a moment as folks are filling out the poll. So the majority of folks are interested in learning more and some interested in testing. And then in terms of EHR-based measures, seems like a large majority are either very interested or somewhat interested in EHR-based measures. Great, thank you. Now I will pass it along to Veronica.
Thanks, Carrie. So now we'll get into updates made to AHRQ's QI software. Next slide. I'll start by briefly covering the SAS QI software updates and focusing on a new feature in the MHI module. In SAS QI, there's a new RefPop user option. So this is the only update to the user options in this release, and it applies exclusively to the MHI module. It's not included in the other modules. So this option lets users specify the type of input data, which can include inpatient discharge data, linked inpatient discharge data, which allows tracking patients over time, and linked inpatient and ED discharge data. So I'd like to note that because the MHIs require different reference populations, users will need to run the software 3 times using the correct RefPop value in the control program. So the values for this option include RefPop 1 for MHIs 1 through 4, which require 1 year of inpatient data. RefPop 2 for MHIs 5 through 7, which use 5 quarters of linked inpatient data. And then finally, RefPop 3 for MHIs 8 through 11, which use 5 quarters of linked inpatient and ED data. So this option is important. It'll help users ensure that each of the MHI uses the correct reference population for accurate calculations. So with that, I'll turn it over to Vivek to discuss changes made in the Windows version of the QI software.
Thank you, Veronica. And hello, everyone. This is Vivek Kumar. I'm the project director on this project on the maintenance contract. So before we get into software updates and improvements, I would like to first walk you through the roadmap to show where we are headed with our 2 Windows-based products. Right now, we are supporting 2 tracks. WinQI, which is our legacy product that's been in place for over 20 years, and Cloud QI, which is our newer platform that we are bringing up to the same level. Cloud QI, in version 2024, Cloud QI supported PSI, MHI, and PQE. And in the new version, which is version 2025 this year, it's now we have added PQI and IQI to the platform. At the same time, WinQI is still being maintained in version 2025. Looking ahead in 2026, we will add PDI to Cloud QI, and in 2027, WinQI will be retired, with Cloud QI becoming the single platform that supports both the legacy and the new modules. Beyond that, our focus will remain on continuous software improvements and ongoing incorporation of user feedback. Next, please. So what's updated in WinQI version 2025? This release of WinQI continues to support all 4 of the legacy modules, while Cloud QI now supports 3 of those legacy modules along with 2 new ones. If you are running a prior version of WinQI, you will receive a notification that 2025 updates are available. Additionally, you can also run Cloud QI in parallel with WinQI on the same machine. This gives you a way to compare output from both the application and kind of gives you a peace of mind while you're in the process of transitioning. We have also incorporated new feedback, user feedback, into the application. Some users told us that the automated run generated an output file with the date time suffix in the file name that interfered with their internal processes. Now you can configure file names and remove this suffix if needed to support your internal processes. Another piece of feedback was that automation script often broke when upgrading to the new version of the software. We have addressed that by adding a simple one-click upgrade process, which will let you upgrade your script from a prior version to the new version. And finally, further details are available in the software instruction document on the website. Next, please. Let's review some of the changes in Cloud QI. The deployment option remains the same as before. You can run it in desktop mode for a single user, install it on a server for multiple users with login, or even run it as a service to integrate with other products. One important clarification to note is that Cloud QI does not mean it's hosted on AHRQ's cloud. You can host it however you would like, on a desktop, a network server, or another environment that works for you. So it's hosted on and installed in your environment. Now, what's new in version 2025? The MHI beta module, we discussed it just before this, has been expanded to include 11 indicators. We also released a minor version 2025.0.1 yesterday, which enables the remaining MHI modules for anyone who upgrades. And finally, similar to WinQI, Cloud QI now lets you configure exported file name to remove the date timestamp suffix that we have been adding when running automation. Next slide, please. So in addition to what we have already covered, version 2025 WinQI introduces some new features. The biggest one is file sharing. In the past, you could only reuse your own uploaded file. Now, you can share those files across all users in your organization. It's not granular yet, such that you can pick individual users or set permission levels, but it does let one person handle the import process while others can use the same files for further analysis. We have also improved file management. You can view all your previously uploaded files without re-uploading, and even see which files have been shared with you while you are uploading new ones. Based on user feedback, we have added a setting that forces users to reset their password on first logging. if their account was created by an administrator. This is for security reasons. And finally, as a feature in Cloud QI, as some of you may be aware, you can switch versions. You can now move between version 2023, 2024, and 2025 for PSI and PQE, and version 24 and 25 for MHI. PQI and IQS are only supported in version 2025, as they are the newly added modules. This gives you more flexibility in working with different versions. I certainly recommend you to install it and can run it in parallel. This is also a good alternative, as Judy mentioned, to using SaaS QI if you don't have access to a SaaS environment. So certainly try that out. Next slide, please.
Vivek, before we move on to the resources, could we please unhide the webinar, I'm sorry, the website update slide, and maybe you could speak to that? We have some extra time.
Let me do that.
That would be slide 36.
Okay, can you bring it up, please? All right. So on the website, you will see that the new modules are showing up. So MHI was introduced in the last version. It's on the website. But when you go to MHI, you will see additional indicators that are now added within this module. You can certainly click on these modules, cards that are on the homepage to go into the details of resources available within each of these modules. On each of these resource page, you will have access to individual technical specifications, risk adjustment parameter estimates, data, benchmark data tables, and change log. So that's sort of one way to go to these resources. You can also access the software page where you can download the software such as WinQI, Cloud QI, SaaS QI. There is also a new FAQ document for MHI specifically that addresses MHI's related questions. So if you go to the MHI section, you will see that document available for you to review as well. Go to the next one, please. All right. So that with that, let's just go through some of the resources that are available for you to use. We are excited to share about a newly created publicly available GitHub resource for SaaS QI. The AHRQ website will remain the main resource for all information, documentation, and code. But we have also created a public-facing repository for the SaaS QI open source code, so you can freely download and explore the code base. With this open source platform, we want to enable community contributions. User can submit issues or pull requests for improvements, creating a more collaborating process, so to speak. The repository also serves as a place to share feedback on documentation, making it easier for others to understand and implement the code. And beyond the code itself, we are building a public collaboration space where stakeholders can connect, ask questions, share solutions, and build on each other's work. So certainly, the link will be on the slide. If somebody can drop the link on the Q&A somewhere, so others can try that out, that'll be great. And also in addition to that, we have also added a new resource on the website. The link is provided here on the slide as well. The page provides a collection of links to evidence-based practice resources tied to the AHRQ quality indicators. We have started with the PSI module, and we will be expanding it with other modules in the near future. Next slide, please. On the website, you will find updated changelog documents for each of the quality indicator modules. We have also posted the version 2025 software instructions and release note along with the updated empirical methods and MHI resources. In addition, we have made research tools available, including the exploratory MHI 365-day research tool. And coming soon, you will see a new diagnostic safety webpage and the SPADE tool for analyzing diagnostic errors. Next, please. So before we close, just a reminder that technical specifications for all modules are available and should be used along with the AHRQ indicator software. Please try to tie them up together. That will give you a better sense of the logic. If you need help, technical assistance is available through our FAQ at qualityindicators.org.gov or by emailing qisupport@org.hhs.gov. And finally, please remember to cite AHRQ in any public-facing material that use the quality indicators. You will find a full citation guideline on the website. So with that, I'm going to turn it over to Kendall so we can start our Q&A discussions.
Great. So I see that we do have some questions in the Q&A, and we're answering some of those as we go. We're going to do a couple of those verbally, but first we'd like to start with a question or two that we've previously received from users and we thought were of value to the larger group. So the first question is going to be about the MHIs. So what are the new MHI measures and what is the rationale for including them in the beta module? Carrie, can you take this?
Great, yes.
Thank you.
So here we have a list of the existing and new measures. So the existing measures were the three different SMM measures at delivery, and there is a scientific rationale document available on the AHRQ website that details the distinction between these. The new measures, MHIs 4 through 11, focus on a mix of mental health and severe maternal morbidity in the postpartum period. We see MHI 4 is another measure at delivery that looks at broad mental health and substance use disorder during delivery. And then MHI 5 through 7 look at severe maternal morbidity through 42 days postpartum. So these measures require inpatient linkage across the 42-day postpartum period. We also have MHIs 8 through 11, which look at several different mental health and substance use disorder indicators, and they include both emergency department and inpatient data across the postpartum period. These measures were developed with an expert work group in response to feedback that AHRQ received during a request for information on maternal health, where users overwhelmingly wanted to see severe maternal morbidity measured postpartum, as many events can occur after the delivery discharge, and where mental health and substance use disorder measurement were flagged as high priority topics for development. So we appreciate your feedback on these new measures and the specifications as they're released. Thank you.
Thanks, Carrie. And
Carrie.
oh, sorry.
Kendall, can I jump in for a second?
Absolutely.
Thank you. Carrie, can you also mention about the research tool that Vivek mentioned, the 365 day?
Yes, so you see here MHI 8 through 11 are the ED and inpatient mental health measures from days 1 through 42 postpartum, and the research tool extends these measures from 1 to 365 days postpartum. So there is good evidence that a lot of mental health and substance use disorder in the postpartum period occurs many months after delivery. So we wanted to put a version of the specifications out there that looks at 365 days. However, linkage to patients through a 1-year follow-up can be challenging for many users, and we do see a large proportion of events occurring in the 42-day postpartum. So the research tool is geared at users that have long-term linkage capacity and are interested in looking at these rates over the year following delivery.
Thanks, Carrie. Our next question is, does AHRQ plan to include failure to rescue measures software? I'm going to hand this to Judy to start.
Yes, thanks, Kendall. This is a question that we have been hearing a lot about over the last couple of years. AHRQ has been working and talking with CMS, and we will be considering releasing FTR software. It's something that we are reviewing in detail. We'll hear more about that. You'll hear more about that in the coming year. It's obviously not part of the current version. We have to go through a very thorough process of assessing how that might be operationalized from our current data sets and our current processes, and then how to fit that in with the existing set of measures, and whether there needs to be a retirement of certain measures that may overlap with the FTR. Carrie or Sheng, would you like to add anything more to that about just the technical specification portion that you're working through in the coming year to decide some of those factors?
Thanks, Judy. I agree with what you just said. AHRQ published FAQ for comparing the difference between the PSI-4 and FTR from CMS. I think there are some really key differences listed there. I think the most important one is CMS measure is designed for Medicare enrollees, while AHRQ PSI-4 is designed for all-payer inpatient population. So we really have to review the difference between those two types of measures and see if AHRQ will be able to publish FTR version in the upcoming years. I don't know if Carrie, Patrick, do you have anything else to add?
Nothing to add on my end. Thank you.
Oh, apologies. Carrie, I think you answered this, but if not, for the diagnostic safety measures, what's the purpose of the technical specifications release without program code?
So we plan on releasing technical specifications this fall. It would include, if you're familiar with ECQM specifications, what is similar to a MAT header where it's measure, definition, numerator, denominator, exclusions, rationale, and code lists, but it doesn't include the CQL logic. And the purpose of that is to socialize the measures with users, get feedback on feasibility and validity from the user perspective as we continue to develop and finalize the final measures for the release in 2026.
Thank
Great.
you.
Great.
Oh,
And
go ahead.
Kendall, can I just jump in there? It looks like from the poll results from when Carrie presented initially earlier about the plans for the diagnostic safety technical specifications, there was a wide majority, over 70%, that noted they were very interested or somewhat interested in EHR-based measures from the AHRQ Quality Indicator Program. And I'd like to pose that question to hear more from those attending who responded, yes, they're interested, on what exactly would they be interested in? Are there specific measure types? What type of resources or tools? If they could pose that in the Q&A to hear more about that, that would be helpful.
All right. So while we are waiting for folks to put those responses in the Q&A, I do have a question for Vivek to answer. Does Cloud QI have a feature that allows us to upgrade our automation script similar to what was mentioned for WinQI?
Yeah, thanks. That's a good question. We are taking an incremental approach. Cloud QI is a little bit set up differently because you have ways to switch between different versions. While WinQI is one version at a time, you can only install one version. So we kind of prioritize WinQI to have this capability where you can upgrade your script from a prior version to new version. In Cloud QI, you can still run that script if you switch to a prior version. At this point, unfortunately, if you were to recreate that automation in the newer version, you will have to just kind of recreate that script. For the most parts, for 2024, from 2024 to 2025, the script should work without any problem. But in the later version, we are looking to incorporate a one-click upgrade for automation scripts in Cloud QI as well.
All right, thanks, Vivek. I am just going through our questions here. This might be actually a question for Patrick. I see Patrick is on the line and I just lost it. Apologies. It's regarding PSI 18 and 19. Do they affect PSI 18 and 19 affect childbirth encounters, which fall into MDC 14? The exclusion criteria include a principal diagnosis code assigned to MDC 15. Newborn and other neonates. There would not be a scenario where we would have a newborn diagnosis as a principal diagnosis on the mother's chart. Should the exclusion principal diagnosis code be assigned to MDC 14? That's a lot, Patrick.
Yes, no, good afternoon. This is Dr. Romano, the clinical lead for the program based at UC Davis in California. And I think we answered that question online, but if the answer was incomplete, please feel free to add more. But basically, it's just a technical exclusion to account for very rare cases in which records are incorrectly coded and incorrect codes are placed on the same record.
All right, thank you, Patrick. And here's another question. Have death certificate data being used in conjunction with hospital data to crosswalk for most accurate outcomes? I'm not sure where the question is or who might want to answer that.
I think I can chime in where the quality indicators currently look at in-hospital deaths, so that would be for the inpatient quality indicators as well as some of the maternal health indicators. And I think this might be a suggestion for being able to link to death certificate data to capture out-of-hospital deaths. That is not currently an option to be incorporated within the HCUP data, but if users want to supplement their analyses using the QIs with out-of-hospital death information to look at how it impacts rates, I think that's a good functionality for users to implement.
Great, thank you. Oh, sorry, my screen just jumped.
Kendall, can I respond
sure.
to a question that came up? There was a question on, does AHRQ plan to evolve the MHIs where they can be employed for accountability purposes? The answer is no, AHRQ does not plan to do that. AHRQ does coordinate with the broader federal agencies. Those on the line may be familiar with the CMS serious obstetric complications measure, which is somewhat similar to certain MHIs, but that is not our part of our work with the MHIs. We have produced them for population level use and not for hospital level accountability purposes. And If there are concerns about that, we ask you to reach out, and especially to be testing out the beta measures that Carrie described, both the 42-day and our research tools. Hope that's helpful.
Thanks, Judy. And this question, I think we will pass it along to Carrie. Carrie, it says for the ECQM measures, have you found they are more accurate than other types of measures like claims-based or surveillance measures? In my experience, we have struggled to get ECQMs to measure accurately. However, there is a push to move to EHR-based measures. I am just curious on the evidence on performance to move towards creating more ECQMs.
Yeah, that's a good question. I think it's a mixed bag in terms of accuracy of claims versus ECQM. The reason that we are moving towards it for diagnostic safety is a lot of the measure concepts that we're looking at require the use of ECQM field because we're looking at imaging and lab test results as part of the concepts. We had considered a broad range of measure concepts, but the vast majority of measures in the diagnostic safety space use ECQM fields rather than just claims-based fields. And we had an expert work group weigh in on measure selection and via a Delphi process. So we're still kind of assessing the feasibility and validity of the measure specifications and trying to address any limitations with ECQM data, but it's really driven by the measure concept rather than our just desire to simply move towards EHR-based measures. So I think in particular, timely follow-up after abnormal cancer screening requires the EHR fields.
And a related question came in, if regarding the ECQM measures, will there be additional resources to help improve the accuracy of these measures? Are there going to be any other resources?
I think we're going to provide kind of the suite of ECQM resources that what you might see for measures in the MIPS program. We will also provide some scientific rationale documentation that detail our review of the measures as we implement in a chart review. But if you have particular ideas for resources that could improve the accuracy or kind of questions or feasibility limitations, please submit it to the QI TA email, and we can follow up offline for particular examples.
Thanks, Carrie. And I think because of oh, sorry, go ahead, Judy.
Kendall, can I interrupt you for a second? And so on the topic of diagnostic safety, Carrie, do you want to share a little bit about the SPADE tool that's being released as a research tool and how that differs from the beta data diagnostic excellence measures that will also be released?
Sure. So the SPADE tool grew out of a lot of literature related to applying the SPADE approach to claims-based data. And we discussed it with our expert work group, and they felt that the SPADE-based tool testing was good for research and investigating particular symptom disease pairs, tracking within your health system over time for quality improvement. But the positive predictive value kind of varies for those measures, so it's meant to be used as exploratory. So for example, if you want to look at particular like non-specific symptoms that might result in a readmission and see how frequently that's occurring within your health system and comparing that across hospitals, that's the purpose of the research tool. It's basically off-the-shelf code that you can use to apply. And it differs from the diagnostic safety measures, which have been sort of rated more highly to capture diagnostic safety issues and are a bit more focused right now on process-based measures rather than outcome-based measures, although we do have some intermediate outcomes as well. And we will have documentation overviewing how the SPADE tool might be used, what some prior literature has shown. AHRQ has had a lot of work developing this approach as a way to identify potential diagnostic safety measures, concepts, etc. Many people use the SPADE tool as a way to identify cases that need further chart review, for example.
Great, thanks,
Thank
Carrie.
you. Kendall, go ahead.
Oh, sure. I was going to have another question for Carrie regarding the MHIs. And if you could just describe briefly how the MHIs compare with maternal health outcome measures available from HRSA, the AIM group, and CMS.
So we have a really detailed document on scientific rationale that overlaps our MHI measures with the HRSA AIM measure and the CMS severe obstetric complications measure. You know, at a high level, the HRSA AIM measure doesn't include mortality. The CMS measure includes mortality and risk adjustment and is geared towards hospital level comparison. The AHRQ measures have options that do and do not include mortality. They're not currently risk adjusted and we're geared more at area level measures. MHI3 in particular is looking at refining the SMM measure numerator. And we made some efforts to refine DIC and renal failure. And so there's some key differences there, but I would probably point you towards that document for more detailed information.
All right, Judy, did you have something?
Oh, I was just going to ask in the last minute here for those, if they're still on the line, that responded back about our question on alternate programming languages other than SAS. There was a split between R and other languages and Python. And so was just curious of those who noted other, if there are questions or specific languages they're looking for, to just enter that into the Q&A. And if they, for those of you who joined and are not coders, but you have coders in your institution that may have other ideas, we encourage you to send any suggestions or your recommendations to our TA support email.
All right, thank you, Judy. So would you like to go to the next slide? Or are we finished?
Yeah, I think, you know what, was there a question, Patrick, because I think we have about a minute before we wrap up. You can end on.
Yes, I can answer. There was a question about PSI-4 that I can answer quickly.
We don't want to leave without talking about PSI-4, everyone's favorite. Go ahead.
So the question was about the outcome of PSI-4. So outcome is this is a risk-adjusted measure of in-hospital mortality among patients who undergo major procedures and experience certain kinds of complications. So the question was, why do we exclude patients who are transferred to other hospitals? The reason for that is that if the patient is transferred to another hospital, then we don't know what was the outcome of their acute hospital episode. We don't know whether they survived or died at that second hospital. So therefore, we don't know what outcome to put on that case. So those records are excluded from the denominator to avoid bias related to how we handle inter-hospital transfers.
Thank you, Patrick. And with that, we are going to end our call today. And if you still have questions that we were not able to respond to, or you think of them after this, please submit them to the QI support team. The email address is there. We do respond to every message that we receive, and we'll use those questions and responses to inform for future communication. So thank you so much to all of our speakers and to all of you for joining us. And that concludes our webinar for today. Thank you and have a good afternoon.
Thank you all.